Okay, good morning. Today I'm going to present on this journal, injectable corticosteroids, take precautions and cautions lah. So this by these two authors, Veronica Ferre and Natalie J. Burrow. So they are from researchers from Canada lah. So this journal is being published in 2016. So I took this for our later on discussion lah. So the article talks about structure of corticosteroid preparations, potential adverse effects and the complications, contraindications and the use of corticosteroid injection in non-spinal musculoskeletal conditions. So these 4 things lah. So we need to know the basic thing first. So the adrenal gland consists of adrenal medulla and the cortex. So this cortex is the one releases the steroid hormone. So classified into glucocorticoids and mineralocorticoids. So glucocorticoids example is cortisol. So the function is to reduce the vascular response, reducing the accumulation of inflammatory cells and downregulation of immune function. So if we see the mineralocorticoids example is aldosterone. So the function is to regulate the electrolyte and fluid balance. So why we need to add the local anesthesia to a corticosteroid preparation. So this is why, because provide the immediate short-term relief and increase the volume and the dispersion of injected, and also provide the diagnostic feedback by the differentiating between the local and the referred pain. So example of local anesthesia that we can give is bupivacaine without epinephrine 0.25% and also lidocaine 1%. So this is the physical properties of commonly used injectable corticosteroid preparations. So they are classified into 2, which is the ester preparations and the non-ester preparations. So if you see here, the injectable corticosteroid, the first one with methylprednisolone acetate, triamcinolone acetonide and beta-methasone acetate. So this acetate group has this ester preparations. The physical properties of this acetate group is that they form a microcrystalline, which makes it to be insoluble in the water. So it has a slower release at the site of injections. So compared to the another one, which is the sodium phosphate, the dexamethasone sodium phosphate and the beta-methasone sodium phosphate, so it has a non-ester preparations. So this one is a non-particulate preparation, it's a clear, so it is soluble in water and it has a quicker onset of effect. So based on the journal, they mentioned that the non-ester preparation has a 5 times good potential than the ester preparations. So the next one I'll talk about adverse effects and potential complication of intra-articular and soft tissue corticosteroid injections. So we have adverse effect, which is systemic and local. So the systemic one, facial flushing, which will last about 2 to 3 days like that, and it's a self-limiting. So the reported incidence is 10 to 15%, and also we have a hyperglycemic effect, those in the diabetic patients. So roughly we have to monitor their blood sugar 2 to 5 days like that, and also adrenal suppression. So those have this adrenal suppression, we must monitor for adrenal crisis for the next 2 weeks after the injection of the corticosteroid. So that's why we have to ask them to avoid all the heavy duties and also avoid going to hiking, all the altitude related issues. And the menstrual disturbance. The second one, the local, is post-injection flare. So this one is reported incidence between 2 to 25%. So after, let's say, the flare is more than 24 hours, then it's advisable to take a joint, to aspirate the joint, so to exclude the infection. So this is for the post-injection flare. And then you have post-injection pain, subcutaneous atrophy, skin depigmentation and soft tissue calcifications. So if you see the potential complications, the local one, usually most common feared one is the septic arthritis. So the reported incident estimated is 0.01% to 0.03%. So other than that is the tendon rupture and articular hyaline cartilage damage. So there's a study here in 2010, systemic review examining the efficacy and safety of corticosteroid injections of the management of tendinopathy. So out of 460 participants, so they had this adverse effect of 31% had a post-injection pain, 9% with subcutaneous atrophy, 1% with skin depigmentation. So as from this study, they came up with the conclusion that methylprednisolone is more soluble than triamcinolone and has a less adverse effect. Therefore, methylprednisolone is more preferred when injecting a superficial structures. So, contraindications to local injection of corticosteroids. So, I have two: sepsis, bacteremia, skin or periarticular soft tissue infection. Another one is intra-articular fracture. So, use of corticosteroid in musculoskeletal disorders. So the first one is articular disease. So it's adjunct therapy for all the for inflammatory arthritis, knee and hip osteoarthritis. So the benefit is for the short-term pain relief and also functional improvement. So this is evidenced by a longitudinal cohort study. So they said in a clinical improvement at 6 months in active sacroiliitis in patients with spondyloarthropathy. So the second one is a tendon disorder. So this corticosteroid is a first-line intervention in trigger finger and Decoraine disease. So it is supported with 2 randomized clinical trials. So reduced pain, short term is 4 to 12 weeks. The intermediate term is about 30 to 26 weeks. Long term is more than 52 weeks. So the next one is we can use it for carpal tunnel syndrome. So it's effective at decreasing the symptoms of idiopathic carpal tunnel syndrome, and it reduces the perineal inflammation or soft tissue swelling within the canal. So any question?